So what have you learned now about the idea of delivering news that a patient is terminal that you didn't know back then when you were just a doctor? And could you have learned that back then, or did you have to go through this process to kind of get there?
Yeah, I don't think I needed to learn that. I think what I watched her doctor do is consistent with how I would have wanted to handle that situation. And you know, as a doctor who works in intensive care units and takes care of people with serious lung disease, that felt intuitively right. Like you have to frame what's going on therapeutically or diagnostically with what the overall situation is, what the arc of the illness is, what can be modified, what can't. So that felt familiar to me, but it was still very different when it was my wife.
For the trainee or the new physician, or possibly for someone who's been practicing for a while, what did you learn about this experience that could possibly help others?
There's a lot of pieces to this, and I don't think there's an easy answer about how to be better doctors than many of us are. And it'd be easy to sort of spout some platitudes. You should listen to patients better. You should try and put yourself in their shoes. But, you know, and there's certainly no, like, solution like William Hurt acted out in The Doctor, where he made all of his med students, I think, have colonoscopies or something like that. It's not going to get us there. But I guess I generally think, and this isn't from my experience, it's from after our initial experience watching my trainees and watching the other doctors I was around, that generally underestimate individuals who turn into patients' ability to understand themselves and the world and their life trajectory and put these things in a bigger context than we allow them to. And I quoted in one of the columns, I can't remember which one, but Don Berwick, who was the Medicare administrator, was giving a talk one day, and he made this point, and I think he had taken the line from somebody else, I then took it from him, but he said, you know, I used to think of patients as, you know, guests in my hospital, and now I realize I'm a guest in their lives.
Wow.
And maybe that's not exactly what he said, but something like that. And that really resonated with me. I was like, yeah, and this is after I had been through this. I was like, yeah, that's right. Like it's not ego, right? But like we waltz into patients' rooms and we think their life is about their illness and what we're doing for them and how we want to help them. It's all coming from good places. And so we try and protect them in terms of how we explain their illness or leaving things out or using vague terms that, you know, don't have concrete meaning necessarily. It could be, there's wiggle room in how to interpret them, right? We don't say simple things necessarily like, you know, this disease will kill you if something else doesn't get you first, or this disease will kill you and most people are dead by 3 years, whatever. But the reality is it's in the context, that's a small part of these people's lives. And so they're able to frame, I think most patients can put into context more information than we give them and figure out where it all fits. And, you know, most people actually do realize they will eventually die. And I actually don't think you have to have a separate board certification to communicate that. And when I listened to my trainees, you know, back when I was on the wards, I would often pull them aside and say, you know, when we would leave a patient's room, I did inpatient service mostly, say, what do you think they heard from what you just said?
Yeah, that's an interesting question.
And usually the response is the same exact thing they said in technical terms. And then I would usually say, well, let's go ask them. And then in would go.
Okay.
And that's not at all what they heard. Right? And it was a pressure-packed situation. I'm standing there on top of them saying, articulate, answer this question, tell me this. But in fact, you know, and then, you know, the sort of discussion is like, okay, let's figure out what the goal is of delivering this information. Is it perfunctory? Like, I'm seeing the patient. I have to say I said this so I can write it in the chart and I move on to the next patient.
Of course.
There's a big part of that, and I get that. But like if we're actually going to try and communicate this complex information, it's actually much more important that it's heard than that we say it. So I actually think that's kind of a useful exercise.
Mm-hmm.
And many doctors do that. I didn't make this up, right? A lot of doctors do go through this drill where after they explain things to patients, they say, now tell me what I just told you.
Right.
And that can be a very uncomfortable moment, even when you do it well, because patients feel like they're being quizzed, because they feel like they're put on the spot.
Mm-hmm.
But if it's done in the right way, with care,
Mm-hmm.
with empathy, with this notion that I need to know if you heard this piece or that
Mm-hmm.
piece, or let's go over this again.
Mm-hmm.
It's really a good way of reconciling
Mm-hmm.
what you're trying to communicate with what's being heard. And everyone will tell you stories like this, of going into a patient's room, giving them all this information, walking out. This happened to me actually. Seeing my attending, saying, well, did you tell them this? And I said, yeah, I explained the whole thing. I said, that patient doesn't speak English.
Wow.
It's like, really? They looked like they understood me.
Wow.
So that's how far it is. And I'm happy to, if I had written about that, somebody else would have commented about what a dope I was, not being aware of it. And that's true.
Mm-hmm.
But there's not much of a distance between not speaking English and not understanding medical jargon.
Mm-hmm. So I'm struck by the duality that you talk about of being a cancer doctor as well as being a caregiver for your wife, and that sometimes doctors aren't always honest with their patients. And I'm wondering why you think that duality may exist.
Well, first of all, I think every doctor-patient interaction is different.
Sure.
The doctor's different, the patients are different. But I think that it's, in general, easier and more expeditious to gloss over complexity and nuance. And it's also a lot easier in any particular visit to just talk about what the action plan is than
Mm-hmm.
to talk about the effects of those actions.
Mm-hmm.
And so I think, I talk about in the column, this is something I was well aware of long before I went through this experience, was this sense that, we've created a world for ourselves as doctors where we can safely move amongst
Mm-hmm.
human suffering
Mm-hmm.
without it destroying us.
Mm-hmm.
And any normal empathetic human would be
Mm-hmm.
destroyed eventually by
Mm-hmm.
that. And I think some of my colleagues, I think it is hard over time. But we need a way to sort of do what we need to do and to
Mm-hmm.
be much more objective than you can be as a family member. I wasn't
Mhm.
ever supposed to be Ruth's doctor.
Mm-hmm.
And that insulation comes at the price, I think, of transparency and clear communication
Mm-hmm.
sometimes. And I don't want to generalize. There's a lot of patients, there's a lot of doctors out there, but I think there's certainly, at least in some contexts, more unintentional deceit
Mm-hmm. Mm-hmm.
than is desirable. And it was a hard reality,
Mm-hmm.
not hard as in difficult, of course difficult, but hard as in immovable. And that's very different from the experience of communicating that with a patient and then going on seeing your next patient or going home or
Mhm.
going for your tennis game.
So how has this experience changed how you are as a doctor and how you are as just kind of a person?
Well, the person part is, it's so complex, right? I've lost my spouse. Right? I've lost the mother of my son. It has not changed my outlook in life. I
Mhm.
feel just as lucky to have met her,
Mhm.
actually here in Baltimore, 20 years ago.
Wow.
I feel just lucky to have met her
Mm-hmm.
today as I did back then. And when she died, I felt unbelievably lucky.
Mm-hmm.
Not for the loss, but for the experience.
Mhm.
We travel through these lives together, and that was a great piece of it for me, like a huge piece of it. And she brought me my son, And she said she felt lucky as well, which is kind of an interesting thing to say when you're dying young.
I want to switch gears a little bit and talk about your role as just a husband. Can you be just a husband when you're going through this with your wife, if you're a physician?
I just had my version of trying to be a good husband, and I think everybody brings to a different, strengths and weaknesses, if you will, or faces different challenges. I had a unique challenge, which is that I knew exactly what was going on at this level of detail, and through my own experience, that the knowledge gap between us was vast, and that was a horrible place to be. I don't know if I'd been better off being naive, because I think then I would have felt completely out of control. Instead, what happened was I felt in control, not of her illness, but of the knowledge around it. And I felt that driving a wedge between us because I knew what was happening. And I knew, and I wrote about this, I think I said I could see the future. I knew that, I think they took the metaphor out, but our lives had been sort of twined together. And I could see that kind of one of the threads was going to stop and the other one was going to go on.
Wow.
And I knew it with certainty, not because some doctor had told me, because I had watched it happen. And I'd
your own
watched
patients?
My own patients and other patients. I had watched husbands go to the elevator for the last time, leaving their dead spouses behind. Not once, but many times. Not just from breast cancer, from other cancers, from other illnesses. I had watched that separation at that moment actually occur. I'd declared people dead and stood there. And so I knew exactly what was going to happen.
You wrote in one of your columns, I knew more than I should. Did this ever help you, or is this the type of situation where ignorance may have been bliss?
So mechanically, on the day-to-day stuff, obviously my medical knowledge helped a lot. Like, okay, you have this going on, I know which doctor. The fact that I was a doctor at Sloan-Kettering meant that that doctor would email me back or call me back immediately. But yeah, I think that it could have gone many different ways, but the chasm between my knowledge and hers was bad for us as a couple. But if we had both been more naive, I think that can fuel a different kind of anxiety about not knowing and not being anchored, and what are we missing and what could we be doing. And I think I've seen people who sort of, where no one is anchored to what's actually going on, almost like verge on I don't want to say hysteria, but just sort of a steady state of panic. That it might have been better for us as a couple, as a unit, but not better for her, actually, because it would have been sort of bouncing off the walls with no purpose. So I don't know. None of it's good. The whole experience was bad. But I can't say, like, given a different set of facts in my background, better off, worse off, would she have been better off, worse off? It's not totally clear. Well, thanks very much for reading my stuff, and thanks for inviting me to talk about it.
Thank you so much for sharing your experiences with us. This has been great. And thank you for joining us.